Hi, I'm Adam. I'm one of the Pediatric ST7s, and I'm just going to be talking about amplitude integrated EEG. So, firstly, what is amplitude integrated EEG? I think of it as EEG for beginners. Essentially, it's a filtered and time-compressed form of EEG. So you use a reduced set of electrodes, and it's usually from two channels, one for each side of each hemisphere, and you get that from four electrodes, but you can have single-channel ones as well. And then the cerebral function monitoring displays this amplitude integrated EEG from one or more channels in this compressed, rectified, and filtered form on a semi-logarithmic scale. And the reason why this is so good is because it enables this raw EEG to be compressed and be shown as a pattern that we can recognize changes in trends or changes in the pattern. And so it's easy for non-neurophysiologists to interpret. But also it does provide you a raw EEG sample, so you can look at the individual timestamp and look at the EEG and see, is there any epileptiform activity at that point. So for me, I've mainly seen it used in neonates, and that's it's used in that case to characterize the degree of encephalopathy after hypoxic insult. So it's for those newborns that are born in poor condition. They may have needed some resuscitation, and they're going to go on to have whole body cooling for 72 hours. You can actually monitor their brain function, which can be severely depressed at the beginning, and then over the course of a few days you notice that the background pattern on their aEEG starts to normalize. But more importantly, in these cases, it really helps us to identify subclinical seizures. Often in neonates, you won't notice overt clinical tonic-clonic seizures, but they will be seizing, and it's good to identify that in changes of pattern and their background EEG. And similarly, you'd have thought then it might be useful the intensive care sort of setting where children have had an hypoxic hit for whatever reason. So then I looked into where is aEEG used in intensive care. I haven't managed to find many units that have reported using it in the UK, but in the first study here at the top, which was an online survey of units in Germany and Switzerland, I believe, they say that 2/3 of their ITUs did use aEEG in non-neonates, and they mainly used it for seizures. But because you've got the two channels, you can also notice side differences. Then I found a paper, this is out of Birmingham, who seemed to be sort of using it more frequently in the UK, and they were trying to see whether or not a PICU physician would be as good at picking up seizures as compared to a neurophysiologist using an aEEG. And so they looked at 101 children who had aEEG on, and 23 of those children had diagnosis of electrographic seizures by a PICU clinician, and then they had an expert neurophysiologist come and review those, and they agreed in 12 of those cases that the children did have seizures. More importantly, and what's quite useful, is that that expert review didn't detect any patients with seizures that were missed by PICU clinicians. So it's really quite a useful tool we can use along with our clinical examination to help us identify seizures, especially in those children that are sedated, for example. But it's not a new thing. So I thought, oh, CFM, it's quite, or aEEG, it's quite a new development. But there's a paper here from 1980, actually, that was showing that they've said CFM was useful in the pediatric intensive care unit for seizure patients, patients with raised intracranial pressure, and after cardiorespiratory arrest. So this is what some of the machines look like. So at the top, we've got quite an old-fashioned one, almost looks like a seismograph with ink and paper. And then we've got below that sort of a single channel one. And then the one that I'd be more used to using, which has two channels for neonatal medicine, and then the ICU cart one here that's probably going to be used at St George's Hospital. It's actually quite capable even of doing full EEG if you have all the modules, but it'll do aEEG as well. And it's quite simple to put on. So they're just 4 probes. You need to have them well spaced apart and a reference probe. You attach them to the head, getting good contact on the skin. In neonates, we would use needles, but that's probably not going to be used in the pediatric population. And then you just connect it as per the picture shown below. So it kind of walks you through it. So this is the readout you get. So on the y-axis you've got the amplitude in microvolts here, and on the x-axis you've got time. And then you've got a left lead showing the actual raw EEG here, and a right lead showing the raw EEG. You also have some other things here that you can play around with. You can check the impedance to make sure that there isn't a high impedance, otherwise you won't get a good tracing and you won't get a good CFM readout. You can also combine the 2 leads if you just want to look at amalgamated into single leads as well. So aEEG is actually really quite simple. There are only 5 main classifications of background activity, and then on top of that you can identify seizure. There is a little bit of problem because aEEG was developed really kind of originally for adult intensive care after cardiac arrest, but routinely used in neonates. And we've got reference ranges for normal values for neonates up to about 3.5 months of age, but we don't really know what the healthy sort of child population, what their background aEEG is, or even for that matter adults. However, the classification system that was designed for neonates is still used in research and is still used to classify adult intensive care and in pediatric intensive care. So for that reason, I'm going to go through the 5 main classifications of background aEEG, and then just maybe some identification of seizures. So the first one, this is continuous normal voltage with sleep-wake cycling. So this is a completely normal EEG. You would ordinarily have one for each side, but this is just amalgamated. So essentially, you need to first look at the amplitude. And a normal amplitude is that the lower border of this is above 5 microvolts, which is here. So the lower border is above 5, so that's normal. The upper border is above 10 microvolts, so yeah, well above. It's continuous, so it's kind of narrow amplitude. And there's sleep-wake cycling, so there's up and down undulation, up and down. And then the raw EEG is just sort of random, no rhythmical movement. So this is a completely normal CFM, in this case in a newborn, but the pattern would be similar in children and adults. The next is a discontinuous normal voltage. So here we look at the lower border. The lower border is below 5, just below 5 if we put a line through. The upper border, however, is fine, it's above 10. There's not really sleep-wake cycling, and there's broad difference in the amplitude. It looks a lot thicker, and there's none of the sleep-wake cycling. So this is moderately abnormal, but actually if I saw this in a newborn that had just had therapeutic hypothermia, for example, I wouldn't be too worried at this stage. Often this kind of tracing will change to the previous one and become continuous with obvious sleep-wake cycling. So those 2 that I've just shown you are essentially normal. I wouldn't worry too much about an infant with those, but again, you have to take the clinical picture. Now, the next 3 are all severely abnormal traces. So the first is burst suppression. So here we've got the lower border well below 5, the upper border, well, it's well above 10, and you get here these bursts of activity. So if you looked at the raw EEG, there'd be nothing, and then sudden activity, and then you'd get nothing again. And this would also call discontinuous. So it's very big and thick amplitude, and there's no sleep wave cycling. And yeah, this is a severely abnormal trace. The next is continuous low voltage tracing. So there's continuous background of very low voltage. So here it's all below 5. The upper border is well below 10, and then there's a few little peaks in between, but essentially there's not much activity going on here. It's all quite severely depressed. So again, severely abnormal. And then finally, the most abnormal one, or severely abnormal, is isoelectric. So here, essentially, there's no activity really in the brain, or that's being picked up. So those are the 5 different background traces that you need to be aware of. So this is just a review of that. So this is the pattern classification I'm talking about. There's also a voltage classification that's used more in neonates. It's slightly simpler, but this pattern classification is what's used in research and in adult medicine. So if we just recap then, continuous normal voltage, the lower border's above 5, the upper border's above 10, and there's sleep wave cycling, so there's narrowing and then thickening of the amplitude. Then discontinuous normal voltage, so the lower border is just around 5, maybe a little bit below. The upper border is above 10, however. There's no sleep-wake cycling, it's quite wide. Then the next 3 are all abnormal, so they've got their red. Burst suppression, so lower border's well below 5, there isn't, and then you get these bursts of activity on top of that. So this is quite an abnormal trace. Then low voltage, so in this one, lower border's kind of around 5, below 5, upper border's well below 10. So the numbers you need to remember are 5 and 10. And then the flat isoelectric line, where you've got very little activity at all. So what it's likely to be used in ITU is for identification of seizures. And actually, if you know the background pattern and what's relatively normal, then any deviance from that or change in amplitude would want you to look at that area of EEG, aEEG, and the raw EEG and see whether or not seizures are present. So this is an example of seizures. So actually, if you looked at this, if you just looked at the sort of values, so lower borders just above 5, I'd say, around 5, so not too bad. Upper borders well above 10, but actually you get these spikes, you get cutouts almost like in a pyramid tent-like fashion, like this, cut out, and then the amplitude's quite high here. And if you looked at that time period, or for example this time period, you see this regular rhythmical activity, which would suggest seizures. Here's a more obvious example. So in this infant, the lower borders, yes, well above 5, uppers above 10, looks kind of continuous, narrow, but then these areas of jumping up, high amplitude, and if you looked at that time period where there's high amplitude, you get this regular rhythmical movement, which would suggest seizures. And then this is another one that's showing a sort of relatively normal trace, lower border above 5, upper just above 10, maybe some sleep wave cycling here, but then these spikes, which are all seizures throughout this, with some areas of resolution in between, but not very long. So this is an hour, 2 o'clock to 3 o'clock, and it looks like 1, 2, 3, maybe 4 seizures within that time. So I thought it would be interesting to just look at some pediatric examples, because we don't have reference ranges, but you can get some differences depending on the pathophysiology. So at the top in example A, this is a 7-month-old infant with a left-sided subdural hematoma. So just looking at this, we can tell that both sides are different. So on the right side, lower borders above 5, upper borders above 10. There looks to be some sleep wave cycling perhaps, although not very much. So essentially, if I saw that, I'd say that's normal. But it is different from the left-hand side. So here, okay, the upper border is above 5, above 10. That looks okay, some spikes here. But then it broadens, so it goes from continuous, this narrowness, to quite thick, discontinuous. And discontinuous is a more abnormal tracing. Now this doesn't necessarily, I don't know exactly how this fits with the disease progression of this infant, but it is quite interesting that just by putting the aEEG on, you could identify the left side of this child's brain, something is going on. The next example, B, is a 15-year-old patient with encephalitis and brain edema, and this is recorded after decompressive craniectomy. So both of these sides show continuous tracing, very high amplitude though, and they say this hasn't really been described in literature. But what you also know is there's not really any sleep-wake cycling, so it kind of fits with the etiology of this child's illness. And then finally, this is an 8-year-old patient with a febrile infection-related epilepsy syndrome. And this just shows an epileptic state. On the top, you can't really distinguish it from the background activity, but on the left-hand side, you can really see these obvious spikes just continuously seizing. And you can see how this isn't much different from the early examples I showed you of neonatal seizures, that even if you didn't know how to interpret a raw EEG, you could look at this, recognize that pattern of high amplitude, and that would tell you there are seizures going on. And then if you're a bit more experienced or feel more confident, you could look at that specific time period and see that there is epileptiform activity going on. So now we've covered all sorts of the main areas of classification and seizures. I thought it'd be just interesting to think about predicting outcomes. Obviously, a lot more research is needed in the use of EEG within the pediatric intensive care unit, but they have done some research. So the first two papers from the same group, and the top one is about peri and postoperative amplitude integrated EEG in infants with congenital heart disease. And they found that the background of their EEGs improved postoperatively in the study of those infants after cardiac surgery. And actually a lack of sleep wave cycling was associated with severe infections. But I suppose what's more useful for us, and maybe as a tool in the future to help guide parents and counsel them, is that they then looked at their development a year on and found that improvement in postoperative EEG correlated with improved neurological development at 1 year of age. The last one also looks at the prognostic value of early aEEG monitoring after pediatric cardiac arrest. And in this group, they looked at 30 patients up to 3 years of age who had had a cardiac arrest, and they found that the background EEG correlated quite well with neurological outcomes when they were discharged from the PICU. So it's certainly a very interesting area and one that needs to be researched more going forwards. But as with anything, there are limitations. And a big part of the limitation is that we have gaps in our knowledge around normal values in healthy children. And it would be really interesting for somebody to study this because it doesn't require much intervention to study normal children. And just so that we've got a baseline of something to compare with. There's an effect of sedation on background patterns. Which often, children in the ICU will be sedated, so that might affect their background patterns. You might not pick up seizures. And also there's a concern because we're using a reduced set of channels, we're not covering the whole brain. And because of that, you might miss seizures. As well as that, because it's compressing a longer time period into very small snapshots, you might miss really short-lived seizures. The other issue is that if your background amplitude is already very high, then we're saying that a seizure occurs, or you might notice a seizure if the amplitude increases. If a background amplitude is already high, then you may not notice a seizure. But with anything, it's just one tool in our arsenal, and if it's used in conjunction with formal EEG for patients we're really concerned, it actually might pick up some patients that are having subclinical seizures or ones that we don't notice because they're sedated and enable us to treat them in a more timely manner. Really important in children that have already had a hypoxic hit to their brain, and we want to reduce damage as much as possible. But with any tool, if we're using it, then we need to be trained in it, and we also need to be reviewing them regularly, at least every 4 hours. So I'd suggest in future we need more studies that systematically investigate the use of EEG in older children and infants. I'll just leave a couple more images that you can look at in your own time as a little quiz and have a think about what they show.